share screen going here. All right. So here we go. So y'all can see the screen, right? Yes? Good.
Yes.
All right. All right. Respiratory anatomy. All right. And we'll get through the functioning here. Now, major function of the respiratory system is to supply the body with oxygen for cellular respiration, disposal of carbon dioxide, and we're going to go through the parts. Let me just get through this really quick. So the upper respiratory system, we have the nose on the nasal cavity, the paranasal sinuses. Remember that we have the maxillary sinus, frontal sinus, ethmoid sinus, and the sphenoid sinus. The pharynx is the large space within the head through which atmospheric gas is going to pass and through which the gas that you are going to eliminate comes back. This pharynx is also shared uh, with the GI, so that the same passage within your head serves both to take in not only atmospheric gas, but also foods and liquids. Uh, it differs when we get to the lower respiratory, when we get to the larynx. Now, the larynx is what is commonly known as the voice box. This is where the vocal cords are located within the larynx. The larynx is cartilaginous. It is made up of hyaline cartilage and elastic cartilage, and we'll go through which is which. One bone that is in support of the larynx is the hyoid bone. That's the only U-shaped bone in the body, and strap musculature that supports the larynx attaches to it, and so it helps with it. The trachea is the conduit. It is the tube through which the atmospheric gas is going to pass. Trachea is composed of hyaline cartilage. Hyaline cartilage. This will then lead down into the bronchi, both right and left. These are the major tubes that come off of the trachea, and then they branch off as well into the lungs. And the lungs are composed of alveoli. These are small air sacs. Now, remember, trachea is lined with my personal favorite tissue, pseudostratified ciliated columnar epithelium. So here you have yet again another opportunity to show me that you've learned this. So we begin here, the nasal cavity. These three folds represent what are called the turbinates, and we'll get back to those. These are the bone, the concha, the conchae, and they're covered with respiratory mucosa, and they're responsible for warming and cooling down the air as you breathe it in. So if it's a very hot day, it brings it to your body temperature. So if it's like 115 degrees, which is not unusual in our Southern California summer and fall, it keeps your lungs from being seared. It also creates a turbulence as you inhale the air and moistens it, humidifies it, so that if you are breathing in very dry air, and very dry air can come in from very hot air or even cold air that's dry, it keeps your lungs from being damaged, and so maintains a nice environment for that air to come down into your lungs. Here we have our larynx. Now the epiglottis right here, we'll get back to, is a doorway, kind of a trap door that blocks off the trachea so that food, when you swallow it, goes down into the esophagus, down into the stomach here, not down into the trachea. If any food get past that epiglottis, though, just a little bit of water, just a little bit of food, and it gets down in here, this is a very bad thing to have happen. And so this is why when food does go down the wrong way, as it does, you have a very strong reaction to it. So when food goes down the wrong way, you're not sitting there just going, you're like, you're coughing up a lung, it feels like. This is so that you can eject that food or liquid back out into the esophagus and it can disappear. If you don't indulge that reflex and that food or liquid stay in here, it'll just sit at this point in the trachea. And this point of the trachea is called the carina. The carina. Clinically, the carina is used for intubation. So now when they're intubating COVID patients, they run the tube down and then they feel it stop. It's called the carinal stop. And so when it hits that, then they know to back it up about a little bit more so that the tube is firmly placed and well nestled within the trachea. Now, if food or anything is in here, your body's immune system will try to get rid of it. And the only way it can get rid of it is by breaking down the cartilage of the carina so that neutrophils can begin digesting it away to eliminate it. Because as you can imagine, as you breathe, and this food or liquid is now bathed in atmospheric gas that's carrying on it pathogens, bacteria, fungus, or virus. It's pretty much the fungus that's going to take root secondary to the bacteria. And so now that little bit of food or liquid becomes a culture of infection. So your body has to get rid of it. And the only way it can do that is by digesting it away so that neutrophils can get to it and it envelops it in a pocket. Well, unfortunately, this will form an abscess. So now this abscess you have deep within your body, which is a terrible result of this. So that's why this is such a strong reflex for you. The lungs, as we see here, sit on the diaphragm. The diaphragm is a skeletal muscle. It's a skeletal muscle, and it is innervated by the phrenic nerve, the phrenic nerve, and I'll spell that for you here in a moment. Let's see. Well, now that's not coming up, and I don't know why. Phrenic, phrenic nerve. And the diaphragm helps to change the intrathoracic pressure in the thoracic cavity so that you can breathe. We'll get more to that in a bit. If there is a spasm of the diaphragm, and sometimes this is caused by, it could be, usually it's caused by a hyperextension of the diaphragm for whatever reason, or an irritation of the nerve endings of the phrenic nerve, it begins this spasmodic twitch, and this is what we call hiccups. This is what a hiccup is. It's this diaphragm giving these contractions, and that's why you get those hiccups. And of course, the best way to get rid of hiccups is just to relax and not think about it, because if you keep thinking about it, then it doesn't stop. Here we see the bronchi that I mentioned, the left and the right. And as you can see here, these cutaways are the ribs. So the lungs are protected not only by the ribs, but by membranes as well. And we'll get to those. The nares are the openings into the nose. And of course, remember the nose is made up of elastic cartilage, elastic cartilage. All right, so these are the lower respiratory system. The larynx, here's that hyoid bone that I mentioned. This is the actual larynx here. Here's our trachea, flexible tube, the bronchial tree, the alveoli, which are small saccule structures, small sacs, and they're covered with fine capillary bed, so that gas exchange may occur. Pleura, pleurae, as it says here up on the screen, are the membranes around the lungs. All right, so there's the nares. And of course, this is the external anatomy. I don't have those listed, so you don't really have to know those. Now, the spaces of the pharynx, and I'm moving down my outline here. Okay, so we have three parts to the pharynx. So our pharynx kind of begins right in here. And so we have a nasopharynx. Nasopharynx borders are the upper nasal cavity down to the uvula. Uvula here is that small structure that dangles in the back of your throat, and it's responsible for the gag reflex. So if you try to swallow anything too big that can't get down here, this triggers you from taking it in too far, because then it won't pass through the remainder of the pharynx. The oropharynx goes from the uvula down to the epiglottis of the larynx. Here are the three turbinates that I mentioned, which are the nasal conchae. And of course, the tongue and the palate. This is an actual cadaveric section showing the turbinates here. Here's our nose. Here's our uvula. This here is our soft palate. Soft palate. This is our hard palate. Hard palate is made of bone, and it's created by two bones, the maxillary and the palatine bone. Tonsils, we have the adenoids that would be here, palatine tonsils, which would be in the back of the throat, and then we have the lingual tonsils, which will be on the base of the tongue in here. The tonsils are part of a structure called Waldeyer's ring. Waldeyer's ring, and it is mentioned in the digestive uh, lecture. And so there's the three sets. It's made of lymphoid tissue, lymphocytes. Lymphocytes is what it is made out of. And this is your immune system uh, early alert. It is going to alert your immune system if anything is coming in that's bad because it traps these pathogens and alerts the rest of your immune system like, oh, we've got something bad coming in. So the tonsils are there for a reason. It's an immunological organ for you. And so that's why it's important to kind of keep them. If you do have to lose them, it's not so bad. I mean, you're not really compromised in a serious level that way, but you do lose a first system alert, as it were. All right. So again, three regions: nasopharynx, oropharynx, and laryngopharynx. And here just shows us the areas as I've given them to you. All right, and this mentions the pharyngeal tonsils, the adenoids, here in the nasopharynx. Oropharynx has the palatine tonsils and, of course, the lingual tonsil. Further down, we can see here, here's our palatine. Palatine are located in what is called the fauces. Fauces, F-A-U-C-E-S, here. The fauces is the doorway into the oropharynx. Here we have a nice view of the larynx. This is our epiglottis right here, the epiglottis. It is made of cartilage. It is made of elastic cartilage, elastic cartilage. Most all the cartilage in the larynx is hyaline cartilage. This is elastic. And again, this serves to cover up the opening into the trachea so that food and liquid are then diverted here into the esophagus and not allowed into the trachea. Here we have our vocal folds, commonly known as our vocal cords. We have a true set and a false set. False are superior, the true are inferior, and then there's a small space right where my cursor is running here called the ventricle. The ventricle of the larynx. And so it's a small space in between those cords. All right. Gas is taken down into the lower respiratory system where we get to the site of gas exchange known as the respiratory zone. All right. So larynx is made of a thyroid cartilage. What's notable about the thyroid cartilage is that it contains the laryngeal prominence, commonly known as the Adam's apple. With the influence of testosterone, this laryngeal prominence really becomes prominent in men and is that Adam's apple that sticks out. Now, this Adam's apple varies in size amongst men. Some men have a really huge Adam's apple, and some men have a very subtle and small one. Women do not have an Adam's apple. And so, one feature of transitioning for individuals that transition from male to female is that one of the cosmetic procedures is called a laryngeal shave. And what they do is they go in and shave down this Adam's apple to give it a smoother, more subtle appearance. Cricoid cartilage is ring shaped and it's made of hyaline. Thyroid made of hyaline. We have paired arytenoid cartilages, also hyaline, with the cuneiform hyaline, and then the corniculate. The corniculate are elastic. So the two types of cartilage in the larynx are going to be the epiglottis and the corniculate. Everything else is hyaline. And of course, here's our epiglottis. Again, elastic cartilage, just as it says here, not hyaline. All right. And the epiglottis also has taste buds on it. So you can taste your food, your meals, all the way down into the epiglottis. And so if you're eating something especially tasty that you enjoy, it seems like that flavor goes like all the way down. And this is the reason why. So here we have the external anatomy showing the Adam's apple here. So the Adam's apple is not the hyoid bone as we see here, but it's this prominence that we see. Now, in Canvas, I've also placed a diagram of the larynx here. Note that the trachea is inferior to the larynx. Also note that the placement of the trachea is anterior to the esophagus. So the esophagus passes posteriorly, trachea is anterior. The rings of the trachea are C-shaped, like the letter C. And the reason they're C-shaped is so that for compressibility. It compresses because it has to. Why? Well, when you're swallowing food, here, you see, as it passes through the esophagus, it's going to push open the esophagus. This is going to compress the trachea. If the trachea were composed the same as the esophagus, that means every time you swallowed food, it would close off your airway as it traveled inferior. This is not a desirable result. Note here the thyroid gland. The thyroid gland. Thyroid gland sits here up against and on the surface anterior to the thyroid cartilage. That's kind of why it's named that way. All right. The glottis is a space. The glottis is the opening between the vocal folds. So the vocal cords are going to kind of open and close as you breathe. When I speak, when anybody speaks, they're held together firmly and they will vibrate. And this is what produces the sound. In instances when somebody has a polyp, a benign growth on these cords, it prevents them from vibrating the way they're supposed to be. And so this will change the voice of the individual and it'll be really raspy. They can't really speak too well. If these polyps occur on the cords of a singer, someone who performs, it's going to change the quality of their singing voice. And so this is why, and it happens usually by trauma. Over years and years and years of singing, it can't help but grow these polyps. it's scar tissue from just using these chords. And so this is why people who sing for a career, their career is pretty much done, you know, later on in life. They don't have that same sweet quality, as it were, to their voice, and especially for opera singers. Uh, and this is why you don't see very old opera stars on the stage. It takes a lot of stamina, of course, just to get through a performance, but the quality of the voice is compromised because of years of use. So, again, false vocal cords are superior to the uh, true vocal cords, and it's the true vocal cords that are going to produce the sound. Epithelium of the larynx in the superior portion is stratified squamous epithelium. Inferior to the vocal folds, it's going to be my favorite, pseudostratified ciliated columnar epithelium. So here we have a dissected larynx with our epiglottis here, hyoid, thyroid cartilage. We're looking at a posterior view here. And here's our cricoid cartilage. This opening is the glottis. This is the space in between the vocal cords here. So here's our arytenoid cartilage, our corniculate cartilage, and then our cuneiforms are right here. They look like a little piece of corn right in there almost. So here's our cuneiform here. Here's our epiglottis and our trachea. All right, moving right along. This is just showing an actual vocal apparatus in a human. These are the vocal cords when they're together. And you'll notice there's like no real space there. But when we breathe, we get this opening. And that opening again is the glottis. And this talks about speech and the sounds that we form. Also, with our voice quality, is the size of your sinuses. So if you have really large sinuses, you're going to have a deeper voice, a more mellifluous voice. A smaller sinus, not so deep, and it'll have a higher quality to it. So this is again why men have deeper voices because of the size of the sinuses. That can't be changed surgically, unfortunately, to make a more feminine voice. That has to be worked on uh, by an individual who's trying to feminize their voice versus having masculine voices. Laryngitis is the inflammation of the vocal cords. So if you get an infection down towards the vocal cords, they swell and then you can't speak. If anybody's ever had laryngitis, this is not such a good thing. I've had it a couple of times in my teaching career, and of course, I could not teach because you would just hear a really loud whisper. You wouldn't hear much at all. And so you have to wait until the swelling goes down before you can speak very well again. Not only is it caused by infection, but it can be due to overuse. So if you're like screaming at the top of your lungs at a venue somewhere, you wear them out and they get inflamed like anything else that if you're really working it. And so then you have to give yourself a rest for a day or two. All right, let's see. Now, the trachea The wall is composed of three layers. You know how I like to ask how many. The mucosa is the membrane lining. And again, ciliated, pseudostratified, columnar epithelium. I don't know why they don't have the columnar there, but you got to add that in there. Pseudostratified ciliated columnar epithelium with goblet cells that make the mucus. We have the submucosa, which is connective tissue with glands throughout. And then we have the adventitia. This is the outermost layer made of connective tissue. And again, here we have the carina. And as it says here, violent coughing will be triggered if any foreign object makes contact with it. So indulge that feeling if something go down the wrong way. So carina, left and right bronchi. These will break up into primary, secondary, and tertiary bronchi further in. Note, we have a right lung and a left lung. Right lung have three lobes. Left lung only have two lobes. Here we have a transverse section through the trachea showing the posterior and anterior placement of the esophagus, again, posterior, and the trachea is anterior. The lumen is the space. The lumen is the space within. Here's our three layers, the mucosa, submucosa, this tan layer here. Note the little cilia to indicate the presence of the pseudostratified ciliated columnar epithelium here. And then superficially, we have the adventitia. Ah, photomicrograph of my favorite tissue right here with the cilia. Some of you missed that on the practicum. Please make a note, show me, it could come up again on the second practicum because here we have it in the respiratory system. So if you didn't get it right, now's your opportunity to show me that you've learned it. And so I'd like to see 100% with you guys with that question. Here's our hyaline cartilage, and here's our submucosa.
Aww.
This is a scanning electron photomicrograph of the cilia.
Thank you.
And cilia
Thank you.
are, okay, I can
Thank
hear somebody speaking. Can you put your microphone on mute? Don't make me call you out because I can see who has their microphone. There you go. Thank you. Now, cilia wave out material from inside the trachea. So everything you breathe in, dust, mites, ash, that all goes in. At the end of the day, it is waved up and out towards your nose. And you can either blow it out, sneeze it out, or even hork it out. If you've been working in the garden or cleaning a garage, someplace that's really dusty, at the end of the day, you've got this stuff in the mucus in the product. I mean, if you look at your Kleenex or towel, you'll be like, "Ooh, it's kind of gray and muddy looking." That was all inside of you. Without the cilia, that stuff remains and it just begins to build up deep in the alveoli. Now, cilia and the membrane can be destroyed, and normally it's destroyed by thermal trauma, not so much chemical trauma. And the thermal trauma is the result of smoking, cigarette smoke, vaping, anything within that smoke comes in and it's irritating this, and it also begins to destroy it. And so this is what leads to the development of the smoker's cough. So that people who are heavy smokers, people who are heavy vapors, and with vaping, from what I understand, the chemicals that are used are really bad. And so this causes an individual to start having that cough. Now, that cough isn't just like a, it's more like a, I mean, you hear them really strain to produce something to kind of get this stuff out because it's compromising their gas exchange. This stuff disappears. Now, your body is smart because it's like, gee, I'm getting traumatized here. What am I going to do to protect myself? So, your body replaces the tissue. It will replace the pseudostratified ciliated columnar epithelium with stratified squamous epithelium, parakeratinized. So you begin to develop a type of skin instead of this nice ciliated membrane that helps wave stuff out. Now it's a toughened skin to deal with that inhaled gas and insult. And so you're going to have this cough. Now, this is a process called metaplasia, where the body changes out one tissue for another. Metaplasia, metaplasia. Now, in people that quit smoking, it can come back, but the longer you have this as a habit, the likelihood that it comes back is not so great. And like I said, this is greatest in people that smoke cigarettes, that vape, and yes, the little green cross pharmaceuticals that people inhale will also cause this as well. All right, just like it says here, smoking inhibits and ultimately destroys the cilia. All right, so we get further in down to the respiratory zone. Now, after we've gone past the primary, secondary, and tertiary into the terminal bronchioles and the respiratory bronchioles, we begin to get into the alveolar ducts. The alveolar ducts. These do not exchange gas. Only the alveolar sacs exchange gas, oxygen and carbon dioxide. So this is our respiratory zone within the alveoli. Alveolar sacs are made of simple squamous epithelium, single cells of simple squamous epithelium. And so here we have our respiratory bronchioles, our alveolar ducts, and here are the alveoli where the gas exchange occurs. Now, because your lungs are composed of alveoli, your lungs have a spongy quality. It's not like a big solid type of organ. I mean, you can dissect out a human lung and put it onto or put it into a pan of water and it'll float on the surface of the water, a normal lung. Now, if you have lungs where this has filled with fluid, the alveoli, then the lung function for gas exchange is compromised. And this occurs in pneumonia when people get pneumonia, it's either viral pneumonia or a bacterial pneumonia, but either way, what happens is because it's an infection, the alveoli become leaky, and so fluid begins to fill up each one. And so this is why your lungs make these noises when you have pneumonia, especially, and they can hear it. And the sounds are clinically classified as do they have rales, R-A-L-E-S, or ronchi, R-O-N-C-H-I, or crackles, like bubbles. You can hear it deep inside. If you've ever been really sick, you can hear that. Well, in COVID, unfortunately, these all become full. And so this is why it's necessary to intubate the patient to make sure that we can get a higher pressure in here for gas exchange because these patients are perishing because they're drowning. They're drowning in their own fluids because of this infection. What can also occur that will cause these to fill with fluid is if it becomes highly irritated. Let's say that you inhale ash from a fire and you're caught up in a forest fire. This is how most unfortunate firemen die. The first responders, men and women, if they're caught out in a fire and they don't have the respiratory apparatus, they don't get burned to death. But because they've breathed in the ash, this begins to fill up not just the ash filling in here, but because of your body's reaction to the trauma, it begins to fill with liquid. So these individuals, unfortunately, drown in their own fluids in a fire. This also happens in uh, plane crashes when the plane is burning up and going down and the cabin fills with the toxic gases. This is what takes it down. So half the time, uh, the people are dead before they even hit the ground in the crash because they can't breathe. Here we have a photomicrograph of the alveoli. Here you can see the single squamous cell construct of the sacs. Alveolar pores are the opening. This is our alveolar duct that leads immediately into the alveoli. We call this the respiratory membrane. It's very thin and allows the gas exchange across the membrane by simple diffusion. Again, alveolar walls consist of a single layer of squamous epithelium. There's a scattering of cuboidal cells within that make surfactant. Now, surfactant is also known as dipalmitoyl lecithin. Let's see, dipalmitoyl lecithin. I always have to kind of spell this out myself. Okay, dipalmitoyl, dipalmitoyl lecithin, lecithin. Surfactant is there to reduce surface tension in the alveoli so that they remain inflated for gas exchange. You begin making surfactant about a couple of weeks before you're born. And so, having created this, your lungs, your lungs on your first inhalation will stay open. Without surfactant, these alveoli kind of collapse back closed. And so Without it, every breath that you take is a struggle. In the past, these babies would die mostly within a week because it was just too hard for them to breathe, and we didn't have artificial respiration or anything for them. Now we have artificial surfactant that they introduce into a little incubator, and they breathe it in, and they're able to breathe on their own until their body begins to make it. This is called hyaline membrane disease of the newborn. Hyaline membrane disease of the newborn. And so it especially occurs in premature infants. And this is one of the reasons why they have to keep the baby in the hospital until they're able to breathe on their own reliably. Mm. Now, all right. We also have macrophages helping to keep the alveolar surfaces sterile. This is a type of white blood cell, the macrophages, and they help keep uh, the alveoli sweet and clean. The dead ones are carried by cilia to the throat, and you either swallow them and digest the goodness right back into your body, or you blow it and sneeze it out. So here we have a finer diagram showing our alveolar sacs. Here we have the capillaries on the surface here of the alveoli. These are elastic fibers that help to provide that elasticity. This diagram shows the thin construct of the alveoli. This shows us that we have two barriers for gas exchange here. We have the thickness of the squamous cell of the alveolus, and then we have the thickness of the endothelial squamous cell here of the blood capillary. So there are two cell membranes involved here where gas exchange has to occur. If anything is filling this up and compromising this thickness, this is where the problems begin with gas exchange. So this is why even just a little bit of fluid is going to cause problems. Now, a little bit of fluid, a little bit of dust, a little bit of ash, and just a dozen alveoli at a time, you're never even going to notice that. When people run into problems is when most of these alveoli begin to fill. Then that's the difficulty. All right, so here's our placement of our lungs. Note we have our mediastinum here where the heart sits. Note the heart beats towards the left. This is why we only have two lobes on the left side and not the three on the right, because that heart is displacing development of a third lobe here. Here's our diaphragm again, base of the lung, apex of the lung here is up near the trachea. Thymus, this is the gland that disappears at puberty. It is a gland that is responsible for teaching our immune system its job. And we'll talk more about that when we get into the immune system, but this is where it would sit. Now, in an individual like this, we no longer have a thymus. Again, it disappears at puberty. So most everybody who's listening to me, If you're in your 20s and older, you no longer have a thymus because it began disappearing when you were like 12 or 13, and it gets replaced. It gets replaced with connective tissue and adipose. So here we have our lung. Now, the hilus or the hilum is the area where the vasculature and the bronchioles are going to be passing in and out. The pleura are the membranes, and we have a superficial and a deep pleura. The deep pleura is the visceral pleura, and then we have the fibrous one. In between the two pleura will a fluid circulate to help lubricate the lung. If the pleura become infected, this condition is known as pleurisy. The texture of the lungs, as I said, is sponge-like, and they will float when they're just filled with air like they should, and you can wad up an entire lung within your hand, within one fist. It will collapse down into that tissue. So a lung is just air, and again, it's just spongy, frothy. All right, you don't have to worry about lobules or segments at all. This just shows us a cast of the bronchial tree. They've injected into the trachea a type of plastic, and it just shows the multiple bifurcations uh, into the lungs itself for gas exchange. All right, let's see. Oh, I forgot to mention the vocal cords are innervated, and this was on the chart that I gave you as well. But the vocal cords are innervated by vagus nerve, the vagus nerve, cranial nerve number 10. Cranial nerve number 10. And this just goes through the pleura, the membranes, dust, the pleural fluid, mentions pleurisy here. All right, so here we have the laryngeal diagram that I've posted. There's also a little PowerPoint in there that will go over the different parts. I recommend that you print this out and that you begin studying it, not only for lecture, but for the next lab practicum. It will help you. Now, on Wednesday, we will continue our lecture with the mechanics of breathing. All right. And that will do it for today. So thank you again for your patience. We got through that. And so we will see you on Wednesday. If you have any questions, let's bring them up on Wednesdays when we're going to have more time because now this issue of my microphone has been resolved. So everybody take care and have a good day. We'll see you in lab this week.